This is going to be topic 20, primary assessment.
Key concepts. We're going to learn how to, after completion of this chapter, you'll be able to understand these concepts. Thorough scene size-up, algorithmic approach to carrying out primary assessment, determine level of consciousness, airway breathing and circulation status, plus the treatment of life-threatening conditions, and the value of vital signs. Patient assessment. Required as a part of every patient contact. Environmental conditions may not be ideal for this. The paramedic must quickly and thoroughly form an impression of the patient's medical condition, assess the needs for additional resources, and continuously assess the scene for safety. And we should use an algorithmic approach to do this. Assess scene to evaluate the safety and the need for resources, determine the general problem, and perform any primary assessment. And the goal of a primary assessment is to find any life-threatening injuries or conditions, and these would be threats to the airway, breathing, or circulation, and identify the need for immediate transport. This is an overall general algorithm of a scene size-up and primary assessment. We're going to talk through it here for just a second. This is figure 13.1 in your book, and first thing we do is do an initial scene size-up, and this is to determine if the scene is actually safe, if I should be taking cover. Is there any kind of hazards on the scene? So we really take an overall look at the scene. Just because you're called to a medical call does not mean that there is complication. The complication is not there. We perform after that an initial assessment, and we'll talk about that here in just a second. And then these are the two categories kind of here. Either it's a trauma patient or a medical patient. In the trauma patient, let's talk about trauma first here. In the trauma patient, the mechanism of injury is important because if they've had enough mechanism of injury and it's been a significant amount, then they have got a ton of energy units delivered into their body. So if it is significant, a rapid trauma assessment should be performed, a baseline set of vital signs, try to obtain a sample history if you can, and then transport the patient. The detailed physical exam and the ongoing assessment, which is continuation. What I mean by that is we are looking for trends or anything that we might have missed, all happens en route. This is if we have a significant amount of trauma. And this is an algorithmic approach. Very rapid, very quick. The rapid trauma assessment is essentially a blood sweep and looking for any life-threatening conditions in any of our major compartments. We're going to kind of talk about the next section here. So next section is going to be mechanism of injury wasn't so significant. So in that we would do a focus trauma. So a focus trauma is essentially whenever the patient tells you what's wrong. So I hurt my knee, I fell down and I hurt my knee, or I fell down and I hurt my wrist. After they tell us what's wrong and we take a look at that specific area, still perform a set of vital signs, get a baseline set. In case things go south en route, we're going to have something to trend from or something to take a look at trending from. Then we're going to perform a sample assessment. Signs and symptoms, allergies, medication, past medical history, last oral intake, and events leading to. So obtain all that information and then transport the patient. And then we would do continuing ongoing assessment. There doesn't need to be a detailed physical because we kind of know what the deal is. The reason we're doing a detailed physical in this patient is because it may be so quickly after the actual injury, they may not even be aware that they're injured, or they might be in shock and having a decreased sensation to that area. Medical, next one we're going to talk about. Focus history and physical exam on medical. Mental status comes to mind on this. So if they are responsive, we ask them of a history of present illness. So what's going on today? Do you have any kind of medical history I should be aware of, and a sample history, and then do a focused physical exam, and this would be related to their chief complaint. After that, we perform a set of vital signs, which gives us a baseline set, and we transport the patient. Ongoing assessment would be a regurgitation or a continuance or a reassessment, if you will, of anything that we've actually taken a look at or initiated treatment on. Was this treatment effective, or was this ineffective, and so on. Let's see what we got here. We have unresponsive patient, and then in this patient, we should actually do a rapid physical exam. The rapid physical exam, because they can't tell us what's wrong, kind of gives us an idea to where to start looking at. perform an initial set of vital signs, and try to take a history of present illness and obtain the sample history, and then transport the patient. And again, ongoing assessment looking for trending. So we'll reassess the patient looking for any kind of indication or clinical indication that might be aberrant or might lead us down another path or might change our original field diagnosis. So the scene size up. Consider in this, the scene is the scene safety. Unsafe scenes should never be entered. Conditions must remain safe for continued work. Many initially appear safe, but then they can deteriorate kind of rapidly. First priority is personal protection, and there are multiple dangers in this. Examples of multiple dangers. Injury from moving vehicles, sharp surfaces. You could have hazardous materials on scene that you're unaware of. This could be a crime scene with crazy people on scene. Falls and slips on unstable surfaces from ice, mud, and so on. Domestic animals, and I'm not talking about hamsters. Hamsters we don't worry about so much. 80, 90-pound pit bulls that are wondering why you're messing with daddy is the ones that we generally get our undivided attention. Body substance isolation is also important in this. You do not want to take home anything that Ajax will not wash off. Remember the unseen potential for exposure to bloodborne and airborne pathogens. Paramedics should apply all body substance isolation, gloves, mask, gown if necessary, scale up or scale down as needed. Proper hand washing is also very important. And the mechanism of injury and illness. In traumatic events, determine the mechanism of injury by obtaining information about the patient's family or bystanders, what they saw, or from inspection, or what the actual layout of the scene is. In a medical patient, you could almost take into consideration that they're a mechanism of injury as well, but this will be obtained from their history of present illness. If they've had asthma before, and today they're short of breath, and you can hear them wheezing when you walk in the door, there's a good chance it was exacerbated by their previous history of chronic asthma. Still, you need to do a full assessment. And then last but not least, the number of patients. Not unusual to focus on events of the patient first. It is essential to determine how many total patients need actual care. So if you need additional resources, if you need more ambulances coming towards the scene, you need to know how many patients you have. Additional resources are called for, establish command, and begin triage if you have multiple patients. This is figure 13.2 in your book, personal protective equipment for body substance isolation, including gloves, gowns, goggles, and a mask. All of that should be nice and handy, and never call. Primary assessment. A general impression integrates observations obtained in the scene survey. The paramedic should concentrate on the patient and ask himself if this patient appears to be very ill or severely injured. And this is essentially the general impression is sick or not sick. Does this patient seem to be very, very sick, or do they seem not sick at all? So just by a gut feeling alone, you can get a general impression of this patient. So do I need to step this up, or can I kind of take my time through this? Mental status. Alert patients have eyes open and appear aware of their surroundings. Be sure that you question them a little bit. Person, place, time, and situation. An example of this is if you ask them who they are and they tell you that they're Abraham Lincoln. Now, if they have an ID that says Abraham Lincoln on it, then by all means they are Abraham Lincoln. But if they're thinking that they're an older president of the United States, I don't think that that's going to cut it. So be sure that they are actually alert is my point. Voice. Whenever someone responds to your voice, they have their eyes closed until they'll respond to your voice. That would be in a mental status that would be responsive to voice. Pain generally requires some goading from us. And what I mean by that is we're going to have to do a shoulder pinch, a trapezius pinch, or do a sternal rub. There's some other methods in here that you can use, supraorbital and whatnot, to get their attention to see if they're responsive to painful stimuli. And if they don't respond to any of that, and they just kind of sit there like a knot on a log, then they're probably unresponsive. This is taking a look at the overall scene. So whenever you take a look at this scene, just be aware, like what happened? Did the patient fall from this chair? Was he sitting leaning back in it? Was he standing up on it? Did he hit his head somewhere in this area here on the corner? Why is he unresponsive, laying down flat? So we formulate off of looking at things like this a general impression of what we thought might have happened. As far as we know, the patient could have been hit by the chair. Airway and breathing. And after our initial scene size up and our general impression and our ABPU, we initiate airway and breathing. So airway. If the patient is awake and alert, the airway is likely being maintained, confirmed by observing the breathing and the speech of the patient. If they're not awake and they have noisy airway or difficulty breathing, be sure to assess their airway. We need to take a look at it very, very quickly. Number one cause of airway obstruction is the tongue, so if they're too conscious to throw in an oral airway, then give them a nasopharyngeal airway. Please remember any contraindications of a nasopharyngeal airway. Example of this would be a basilar skull fracture. We probably don't want to snake anything into their brain pan area. The oropharyngeal airway itself, if they have a gag reflex, we don't want to generally put that in. They'll be lying flat on their back if there's possible trauma, and they could vomit. So always take in the BLS considerations of the airway when applying them. Once the airway is open, it must be reassessed to make sure that it is clear. Fluid should be suctioned out and repositioned as necessary. If there's any kind of foreign body airway in there, please get it out. Whenever we're looking at breathing, we should look, listen, and feel. Look and inspect. Also at this time for chest wounds, we should expose the chest. Listen, not only listening with our stethoscope before effective air movement, if they're wheezing, if they're not wheezing, if they're dropped a lung, if there's no lung sounds on that side. All of this should be noted at this time. And then feel. Palpate the chest to assess for potential life threats. An example of this would be a paradoxical movement of a flail chest segment, or a crepitus, the mandible is broken away from the sternum, things like this. So please inspect and palpate the chest during this time frame whenever you're looking at breathing. Give them a full assessment. Methods used to look at painful stimuli are things like a sternal rub or trapezius squeeze. These are some pictures of those. Other methods are supraorbital pressure and mandibular pressure to get painful stimuli going. Now, again, remember, ABPU is the acronym that we learned there. So if they are alert, be sure that they can answer questions. Person, place, and time at a minimum. Person, place, and time and situation would be better. Verbal, that they respond to verbal stimulus. Pain, that they would respond to some kind of painful stimulus. And then unresponsive would not be responsive to painful stimulus. So circulation. Whenever we check for a pulse, please take a look at both the radius and the carotid simultaneously. If the person has a radial pulse, there's a good chance they have a good blood pressure. We should always take a set of vital signs. However, they have enough blood pressure to perfuse the radial artery. Any kind of bleeding that we would see needs to be immediately further evaluated. If it is arterial in nature, we need to stop it, or we're not going to get them to the hospital before they bleed to death. If at this point as well, whenever we're looking at circulation, if the patient is unresponsive and can't isolate and tell us, here's where my injury is, but they're bleeding, and we know they're bleeding somewhere because we can see it on the ground, we should do a blood sweep starting from the head and going all the way to the toes, looking for potential life threats. Skin should also be an assessment during this time. Cool, clammy, and diaphoresis is caused from shunting of the peripheral vessels towards the core. Vital signs. At this point, whenever we get through with circulation and we assure that circulation and bleeding, both active externally and internally, have been noted, we should get a full set of vital signs. This is our baseline set, and what this will do for us is this will give us the ability to assess whether or not our patient is going to trend upward or downward from there. This is a paramedic performing a blood sweep using gloved hands during the primary assessment. The sick or not sick decision after or making a priority decision comes next after the scene survey. What additional resources do I need? Is my patient alert? I do an ABC assessment, and then at this point here, I'm essentially figuring out what priority am I going to be transporting this patient in. So if this patient is sick, I'm going to be transporting emergency. If they're not sick, then I can probably transport non-emergency. And this assessment is made by integrating all of your findings in your primary assessment. High priority patients generally will require life-saving interventions. Packaging takes place before transport to the hospital. So in the high priority patients, gunshot wounds to the chest, you're going to need to seal off those holes and decompress that chest as necessary. You might even require an airway, which you might need to get aggressive with. Low priority patients on scene treatment prior to transport is absolutely okay. These are clues to life-threatening condition, and this is table 13.1 in your book. Poor general impression, unresponsiveness, decreased level of consciousness, difficulty breathing, shock, complicated childbirth, chest pain, uncontrolled bleeding, severe pain anywhere, or multiple injuries. Focus history and physical exam. This is performed after the primary assessment and priority determination. Responsive patients, focus history and physical exam. Unresponsive patients, we do a rapid physical exam on. Trauma patients with significant mechanism of injury, we do something called a rapid trauma on. And a rapid trauma assessment and a detailed physical exam are performed on the patient en route. So we have responsive patients, unresponsive patients, and trauma patients. On the responsive patient, what's going on today? Wherever they tell us the injury is, that's where we're going to focus on. On an unresponsive patient, we need to do a rapid trauma, essentially, and figure out whether or not, or rapid physical exam to figure out if they have any life-threatening illnesses. And then on the trauma patient, rapid trauma assessments if they're unresponsive or high mechanism of injury. On patients that are isolated trauma, example of this, I sprained my wrist, then a focused exam would absolutely be fine. In conclusion, paramedic assessment starts the moment he or she pulls onto the scene. Observation skills are key to rapidly identifying hazards, determining if any additional resources are needed, and determining when to move quickly into a rapid transport mode when a critical ill patient is present.
If you have any questions concerning this topic, feel free to contact me. My name is Roy Smith, SmithArt@SamaritanEMSOK.com or 405-492-8243. Thank you.